Surgery of the ear, nose, pharynx, and larynx. Otorhinolaryngology. Anytime we do surgery on the ear, it includes outer, middle, and inner ear. In today's lecture, we will be talking about key anatomical structures. We will also be talking about case planning, instrumentation, prepping and getting ready for ear procedures, draping, and then the common procedures discussed in this chapter. Many of the patients we encounter in the operating room when dealing with ear surgery may have a hearing deficit. Considering this, it should involve the entire team to be alert and accommodating to the patient. Two types of hearing loss that we encounter are conductive hearing loss and sensorineural hearing loss. Conductive hearing loss typically affects the middle ear. It's fluid accumulation of the middle ear, and the common cause for this usually is ear infections or conditions that block the eustachian tube, such as allergies or tumors. It can also be malformations of the outer ear canal or middle ear structures. Most commonly, this is found in children. Conductive hearing loss can be temporary or permanent. Sensorineural hearing loss is most often permanent. It usually occurs as a congenital anomaly or at birth, prior to birth actually. Sensorineural hearing loss is damage to the inner ear, usually to the nerve fibers. Once nerve fibers are damaged, they are unable to carry the signals to the brain for interpretation. Our ear is divided into three sections known as the external ear, middle ear, and inner ear. The portion of the ear that is visible to us that we can see, of course, is the external ear. Our external ear includes the outer surface of the TM, tympanic membrane, and all structures that lie lateral to the TM. Our TM serves as a barrier between our external and middle ear. All structures that lie lateral to the TM include auricle, known as pinna, which is a cartilaginous structure that gathers sound waves, our temporal bone, external auditory meatus, which leads to the final structure known as the external auditory canal. Our external auditory canal is lined with glands that secrete a waxy substance called cerumen, also known as earwax. Our middle ear includes the inner portion of the TM, our ossicles, which are our malleus, incus, stapes, the opening to the eustachian tube and opening to mastoid cavity, as well as a portion of the facial nerve. The inner portion of the TM vibrates in response to sound waves, which then allows for transmission to the ossicles. The malleus, also known as the hammer, is the most lateral ossicle and is actually embedded in our TM. Our incus, also known as anvil, connects our stapes to our malleus. The stapes, also called the stirrup, transmits the received vibrations to the inner ear by way of the oval window. Our eustachian, also known as auditory tube, it links the nasopharynx. It also helps to equalize the pressure in the middle ear. The disadvantage to the auditory tube or eustachian tube is that it is the way that bacteria travels from our nasopharynx to our inner ear, which in turn can cause ear infections. The inner ear is an air-filled chamber located in the temporal bone. Our inner ear structures help with controlling our equilibrium, so keeping our balance, and the body's sense of position in space. The structures of the inner ear are the cochlea, semicircular canals, vestibules, oval window, and auditory nerve. Our cochlea is the spiral cavity. It kind of looks like a snail, so that's the easiest way to remember. And it contains the organ of Corti. It produces nerve impulses in response to sound vibrations that are sent to the brain for interpretation. It is also lined with cilia, so this is what helps to carry those vibrations along. Our semicircular canals are 3 fluid-filled bony channels, and they are responsible for maintaining our balance. Our vestibules, they are the central part of the bony labyrinth in the inner ear, and they also help with our equilibrium. The oval window is the membrane, which is a covered opening that leads from the middle ear to the vestibule of the inner ear. The pressure that builds up on the oval window is eventually transmitted through the stapes, which presses onto the cochlea. So this is all part of the transmission of sound waves. Our auditory nerve, it helps carry the sensory information from the cochlea to the brain. So how does hearing work? Hearing is a neural interpretation of sound transmission. Nerve transmission occurs from the basilar membrane to the cochlear nerve. The whole process is lined out for you below. So what happens is the basilar membrane vibrates against our malleus, which is attached on the posterior side. This then causes vibration of the incus and stapes, which is connected to the oval window like I mentioned before. That's when the pressure builds up, and from there that pressure or the sound is transmitted into the perilimb of the cochlea through the vestibular membrane to the basilar membrane of the organ of Corti. Anytime we do a clinical examination of the ear, there are certain devices that we can use. When we are doing a clinical examination of the ear, we're usually looking at the external canal, the auricle, mastoid, surrounding tissues, and what we're looking for are signs of infection, inflammation, neoplasm, scars, and lesions. Some devices that we use are the otoscope, microscope, of course a tongue blade, and a pen light. And then we can actually get more in-depth findings by doing a CT or MRI. The otoscope is usually initially used to examine our tympanic membrane. Your ceramin may be removed to get better visualization. Usually if we remove ceramin, we use some type of ring curette to scrape the earwax out of the canal. If we need further examination and the otoscope just isn't cutting it, we can use a microscope to get better visualization. Typically, a microscope exam can be formed with a 250 millimeter lens and speculum. Of course, there are other lenses that can be interchangeable for the microscope depending on surgeon's preference and what area of the ear we are looking at. Nasal and oropharyngeal exams are usually performed with the tongue blade and then a pen light to see down the throat. Also, we can use the light from the otoscope to detect blockage of the eustachian tube. When we look at case planning, we also need to look at preoperative considerations. As discussed with every week and lecture when we talk about specialties, we always want to look at preoperative considerations. These include positioning, prepping and draping, irrigation, and so forth. When positioning the surgical patient for ear procedures, we will usually place a patient in supine with their head turned with the affected ear side up. It is not uncommon to also place a donut headrest underneath the head to stabilize it and also prevent pressure buildup on the opposite ear. Prepping and draping is centered around the ear and the post-auricle area. If we are doing a skin graft, just remember a secondary site may be prepped or should be prepped. That means that you're going to have special draping around that secondary site. With prepping around the face or the ear, a circulator must always be cautious that some solutions can drain into the ear canal, causing injury or damage or puncture the tympanic membrane. To avoid this from happening, we usually place sterile cotton balls, and this will keep any draining or dripping of the solutions into the ear canal. Anytime the circulator preps, she will prep the site extending to the cheek, occiput, temporal bone, and upper neck. After prepping, we will usually drape with a specific drape designed to fit around the ear. Some surgeons or some facilities may also use placement of 4 towels when we are draping. It's not uncommon to use the 4 towels to do a turban style head wrap and then place the drape, or just lay 4 blue towels around the designated area like normal draping. The surgeon may or may not use a stapler to keep the drapes in place. Sometimes to do this, they may place staples through the towels into the skin. If so, just remember at the end of the case, you will need a mosquito to remove those staples out of the skin. Also, be cautious when removing the drapes that you have all of the staples removed out of the skin before you pull on the drapes or towels to prevent damage to the face. When we talk about ear surgery, we need to look and take into consideration the instruments and supplies. First of all, irrigation can be used, which I mentioned earlier in our preoperative considerations. Usually a suction irrigator in ear cases is used to remove bone fragments or when using a drill. This suction irrigator irrigation is a combination of a Fraser suction tip and a smaller irrigator. Instrumentation of the ear usually includes small and even plastic surgical instrumentation. Most commonly, you will see hook retractors, mosquito forceps. When we are cutting skin or using knives, it's not uncommon to use number 15 blades, 11 blades, or 12 blades, as well as small, delicate skin forceps. We also may use several types of small spring retractors, and then micro instrumentations can be used often too. Just remember, our micro instruments are smaller than the regular ear instruments, so they are very tiny and delicate. Anytime we use the micro instruments, we usually use a dedicated light source that is directed over the mayo to allow you to have visualization to help you better identify these small instruments when you're passing them to the surgeon. Just remember, all micro instruments should be handled gently and protected from any type of damage. Please look over and familiarize yourself with all of the illustrated instruments on pages 666 all the way to pages 673. You may not need to know all of these for the test, but it is important for you to understand what they look like. Speculum holder. So our speculum holder, it provides an external structural support to the ear. So we basically just put the speculum in the ear, like when you go to the normal doctor. We will put the little speculum in, and it just gives the doctor better visualization to look at the ear canal or auditory canal, external auditory canal, as well as to be able to place instruments down there to take care of whatever they are trying to work on. We also use autologic endoscopes. Oh, one thing I forgot to mention that's listed on this slide too is the surgeon sometimes often will use the speculum because it frees up both hands. And so just remember, our speculums do come in different sizes. So we'll have small speculums for pediatric patients, medium speculums, and then big speculums. Usually, I don't pull out the smallest speculum when doing these cases. I will often go for the medium or even bigger ones. And when they ask for it, I will pull up 2 or 3 at a time and let them choose the size that they want to use. Our otology endoscopes that we use, a lot of times when we're doing ear surgeries, it's not uncommon to use endoscopes. Again, we're going to be dealing with your smaller endoscopes to visualize parts of the ear anatomy that's difficult to see by the eye or even through a microscope. So just like with any endoscope, we need a connected light source to be able to put light down there to see what we're looking at. And also sometimes we might use a camera, or they might just use the scope, just look through the scope themselves. Most of the sizes of the scopes that you're going to see are 2.7 millimeter or 4 millimeter. Some other equipment and supplies that you might see in ear surgery, again, are power drills. Anytime we're dealing with like the mastoid bones or any of the bones of the ear, it's not uncommon to use a power drill to get to the area that we are working on. Just remember, our drills are going to be pretty smaller than your normal drills that you use on like orthopedic or neuro cases. They will be small cutting or diamond burrs, and these are going to range from 0.5, which is really small, to 7 millimeters. You as a scrub need to be familiar with how to change out your drill bits or diamond burrs and know what perforator or what tip these cutting burrs go into. So just be on the lookout whenever you're setting up this case that everything aligns properly so the drill will work well during the case. Operating microscope, we know what that is. It's used in all procedures, especially on the middle or inner ear. So anytime you're working on the middle or inner ear, you know you're going to need a microscope to get visualization because you can't see it without that. I mentioned earlier the operating lens. I talked about a 250. It's the standard lens, but again, depending on what you're working on, the sizes can vary. Surgeons prefer 200, 300, or 400 millimeter lenses. Be very careful when handling these that you don't scratch the lens and you place them back in their protective covering if you remove them to switch them out. Also, some facilities, you might have a standard 400 millimeter lens or 250, standard lens on there at all times. If you switch out for the case, make sure you switch back to the 250 standard lens and put it back on the microscope. Often the most normal sponges that we use on these types of cases that we're discussing today are usually your 4x4 Raytex sponges. I hate that they call them 4x4 Raytex, so your Raytex sponges. Lap sponges, if you're dealing with any major surgery like behind the ear, into the face, you might use lap sponges. Our cotton pledgets and cottonoids. All sponges and sharps should be counted at the beginning of the case when doing ear cases. So ear cases are not, avoidable when we're doing counts. Make sure you do them at the beginning, during the case, at the end of the case, like we usually do. Ear dressings, they can be pretty simple. We can just place a cotton ball on the ear, or it can be very complicated. 2 types of bigger dressings besides the cotton ball are your mastoid dressing and your glass cock dressing. Your mastoid dressing is applied after a complex procedure of the ear. Usually anytime we're dealing with the mastoid bone or we've drilled into the mastoid bone, there's going to be leakage. So this dressing will consist of a lot of fluff gauze sponges, and you'll cover the ear and incision, and then you will do a rolled gauze or Curlex around the head. Kind of like when you see scary movies where they've done brain surgery or something and they have the cling or Curlex wrapped around the head. That's what this will actually look like. And so that Curlex will hold the fluff dressings and whatever else you've placed underneath that in place during the recovery process. Glasscock dressing, this is usually used on minor procedures of the ear, such as like a stapedectomy or tympanoplasty. This dressing is actually pre-packaged, so you just open it up onto the field, and it's going to have gauze sponges with Velcro straps. So once you place the gauze sponges, you can pull them around the head and secure the dressing in place by snapping those Velcro straps. So again, mastoid's complex usually, glasscock is more minor, and then you can just use a simple cotton ball on the ear, maybe with a Band-Aid or tape to keep it in place. So we don't have a slide for medications, but just like with all other cases that we talk about, you're going to need some type of anesthetic when you're dealing with the ear. Lots of times we use like gel foam, Surgisil, any hemostatic agents, antibiotic solutions, and of course irrigation solutions. It's not uncommon to put antibiotics in your irrigation solutions when doing cases. And then any types of lidocaine, of course with epinephrine to keep and control bleeding and vasoconstriction. I mentioned gel foam, but some other hemostatic agents that we use are Helostat or Pledgets to help be applied directly to the tissue that's bleeding to stop that. And then any antibiotic solution, it can be just instilled into the ear. It's not uncommon. And sometimes I've even seen post-operative, like at the end of the case, where they drop antibiotic drops into the case, or into the ear, not the case, my bad. So let's start talking about some procedures. Myringotomy and myringoplasty are a little bit different. So your myringotomy is actually making a surgical opening into the tympanic membrane to release that fluid from the middle ear. So you got to go in and make a puncture, and what this does is it allows that pressure that's been building up in the ear to equalize itself. We must get equalization of air pressure between the middle ear and the outside barometric pressure. So that trapped fluid's going to drain, and it's going to drain by a tympanostomy tube that's placed in after we make the incision. And so the ear tubes, right? All the times we see kids, I mean even adults, it's placing that ear tube. That tympanostomy tube is placement of ear tubes. Your tubes are usually not removed. So once they're placed in, they're left in until they fall out. A lot of times, just as the patient gets older, they'll fall out. Sometimes they fall out before they're supposed to, and the patient has to come back. But most often, we do the ear tubes or myringotomy in children. So in a myringotomy, in this procedure, basically when we talked about the fluid buildup, it's known as effusion. So effusion is fluid in the middle ear. It's often caused by inflammation. It can also be caused because airflow between the nasopharynx and middle ear is inadequate or it's been blocked. So your negative pressure in the middle ear and retraction of the tympanic membrane occurs, causing dysfunction. If it's left untreated, effusion may lead to infection, mastoiditis, hearing loss, unfortunately perforation, which we don't want to happen, and it can also cause the patient to lose its balance or be off balance. In the myringotomy, under technical considerations, what you really need to know about this is that one of the specialty instruments that you're going to need is an alligator forceps, and these forceps are used to grasp the tube and pick it up, and for placement of the tube down into the canal. Into the tympanic membrane. You want to be careful that when you're loading the tube, they're really tiny, that you don't drop it, and you also need to load it correctly in working order, so when the surgeon grabs it to place it, it's in the right anatomical order and can be put in easily. You're also going to have to take into consideration, as when you're passing this, that you do not make him look away from the microscope, so you need to pass it directly to the surgeon in working order with the microscope. Myringoplasty, this is a little different. You're actually closing the perforation in the tympanic membrane, so it's a non-healing hole in the tympanic membrane that you need to go in and close. So what are some causes of this perforation that takes place? It could be in a persistent opening after removal of a tympanoplasty tube. So if you've went in and removed the tube where that tube was, the hole doesn't close over like it should and it's consistently opening. Some type of blast injury, or in kids, let's face it, they put foreign objects in their ears, their nose, their mouth, so it can be a penetrating foreign body object in the ear as well. So to do this, the surgeon's going to perform the myringoplasty. He's going to be on a sitting stool, so make sure you have one available. You need one with wheels so he or she can perform. Some of them prefer a back on the stool. Some of them like a non-back stool, so just know what their preference is. And for this procedure, you're definitely going to need a paper patch or a fat graft or something to close up the hole. So the technical consideration for this is you will need something to close up that hole. Tympanoplasty is performed to treat several disorders that affect the tympanic membrane. Usually the conditions include, like we've been discussing, the non-healing perforation, dysfunction of your eustachian tube that causes that retraction of that TM, and then a cholesteatoma. And also, anytime this happens, like we keep talking about when we talked about myringoplasty and myringotomy, we don't want to get inadequate airflow between the nasopharynx and middle ear to cause negative pressure to build up. Anytime that negative pressure builds up, it's going to cause the tympanic membrane to vibrate incorrectly, which if it's vibrating incorrectly, that can also cause a perforation to occur, or the cholesteatoma as well. The cholesteatoma can cause infection, otorrhea, bone destruction, hearing loss, and paralysis of the facial nerve. When we talk about a cholesteatoma, that's why we're usually doing a tympanoplasty. Of course, it can be from the other considerations that are dysfunctions that we talked about. But basically, a cholesteatoma is like a tumor or something in the ear. And so this blockage is going to cause that negative pressure to build up. So surgical removal of the cholesteatoma and mastoid bone may or may not involve reconstruction. So anytime we're doing a tympanoplasty, we're doing surgical removal of the cholesteatoma and mastoid bone, and it may or may not involve reconstruction. Two methods that we use are the underlay method and the overlay method, or underlay technique. Underlay technique is where we go in and we lift, the tympanic membrane is lifted away, and the middle ear is filled with gel foam and a support graft. An overlay, so if you're overlaying something, it's usually because it's a large perforation and the TM is really damaged. And so that means that we need to go in, and from the damage that's occurred, there's usually remnants of the TM and bony canal skin. And so we need to go in and remove those. And that bony canal is enlarged, so we have to make it bigger with a drill, and then we're going to place the fascia or skin graft over it. There are 5 classifications. I'm not sure where they are in the book or if the book talks about them. I didn't find them, but you do need to be familiar with them. And so these 5 classifications of the tympanoplasty procedures are basically going to depend on the extent or damage to the eardrum and middle ear that is affected. So type 1 tympanoplasty involves repair of the TM alone. So your middle ear is normal. All you have to do is repair the tympanic membrane itself. Type 2, it involves repair of the tympanic membrane and the middle ear. So both are affected. Type 3 involves removal of the ossicles when there are large defects in the malleus and incus. So if the disease or something that's happened has gotten so bad it's affected the ossicles, that's type 3. So you have to go in and remove the ossicles because the malleus and incus has been affected. Type 4 is a repair when the stapes is movable. So the stapes is moves, but the cruna is missing. So your stapes moves, but the cruna is missing. And type 5 involves the repair of a fixed stape. So the stapes does not move at all. Type 2 tympanoplasty is the class that is most commonly performed. So usually when we do this, we go in and repair the tympanic membrane and the middle ear. Anytime we have causes such as a cholesteatoma, an unreconstructible posterior canal wall, a contracted mastoid, so our mastoid is contracted, any neoplasms, which are cholestastiomas, usually your tumors, and then any non-functioning eustachian tubes. It's often going to require us to fix that by doing a mastoidectomy and tympanomastoidectomy. So we can do a mastoidectomy and tympanomastoidectomy. Mastoidectomy or tympanomastoidectomy is removal of the diseased bone, the mastoid air cells, and all the soft tissue lining of the air cells of the mastoid. So in order to do this procedure, for whatever cause we're doing it for, you're definitely going to need your operating microscope. So we've been talking about the cholesteasioma, and I mentioned earlier what it was, but the cholesteasioma is a benign tumor of that middle ear that's caused by shedding of keratin and the chronic otitis media. So shedding of keratin in the chronic otitis media. So your otitis media is shedding itself because you're suffering from some type of chronic issue that's causing it to build a tumor. Cholestasioma, eustachian tube dysfunction, neoplasm, congenital malformation of the middle ear may block airflow to the mastoid bone and cause that chronic mastoiditis. So cholestasioma, eustachian tube dysfunction, neoplasm, congenital malformation of the middle ear may block airflow to the mastoid and cause chronic mastoiditis. In this procedure, what you need to know basically is it's going to be a post-auricle incision. And then you're going to make your first post-auricle incision, and then you're going to have to go in and make your second incision for the skin graft portion of it. Usually you'll need a graft block in order to place the graft. And then also at the end of the case, you're going to use a special dressing. So once the incisions are closed with your 3-0 or 4-0 sutures, it's going to be different. You know, we talk about this all the time. Based on surgeon's preference, you're going to have to pack that external auditory canal. So when you're packing the canal, you'll pack it with gel foam. And then as for the mastoid cavity itself, just like mentioned before, so you'll put gel foam down in the auditory canal, and then you'll put that mastoid dressing that we talked about earlier and apply it over the wound. Anytime a patient suffers from profound hearing loss related to sclerosis of the stapes, it's going to require us to do a stapedectomy, ossicular reconstruction. So a stapedectomy is the reconstruction of the ossicles to restore conduction to the oval window. So remember, like we talked about before, that we want to maintain that pressure buildup to help with transmission of vibrations all the way from the stapes to the cochlea. So as the sound or transmission is traveling through all of the structures, your sound is going to amplify as it travels. So it gets louder and the vibrations get stronger. So it amplifies as it's traveling through all of the structures of the ear. So why do we usually do this? I mentioned sclerosis of the stapes. So autosclerosis of the stapes generally begins after a patient has reached the age of 30, and then it progresses with age. In this procedure, why we're doing this is because when that sclerosis happens, it's going to prevent vibrating and carrying the stimulus to the structures that it needs to. For this procedure, a prosthesis will be placed into the stapes to continue to allow the transmission of the sound waves or vibrations to occur. For technical considerations, you definitely need to know in this that the TM is elevated and the stapes superstructure is removed. So when we go in, usually for this procedure, they're going to use like a sickle or a Howell's knife to elevate the TM and remove that posterior bony ledge. And then once the TM is elevated and they have visualization to the ossicular chain, they're going to go in the ossicle chain, find the stapes, and then that stape superstructure will be fractured. And how we fracture that is with a Rosen needle and microcup forceps. So we go in and fracture that, and then we get down to the stape superstructure and remove it, usually with a CO2 laser. So we talked about hearing loss at the beginning of this lecture. So sensorineural deafness is severe. It's permanent. So as time has gone by, we have gotten better with technology, and patients who have been born at deaf or lost their hearing at an early age can be candidates for what we call a cochlear implant. And so what this cochlear implant is, it's placed in the patient and it's used to transmit external sound, so when we talk, directly to the eighth cranial nerve. So it's used to treat deafness. One thing you need to know about cochlear implants is that they are contraindicated in children under the age of 2. And the reason for this is just because often during the rehabilitation process, the patient isn't old enough to understand what's being spoken to them, to understand what they're learning. So we usually wait till children are over the age of 2, so we'll delay it till they're 2 or older to place the cochlear implant. So just remember, age of 2. The cochlear implant actually has 2 components. So we're going to go in and provide perception of sound by the 2 parts. One part is an internal component that houses several electrodes, and it's placed under the skin behind the ear. So we're going to go in and actually lift up the skin behind the ear and place the implant inside there. The second part is the actual microphone, so it sticks out and it's placed in the external ear, so it's picking up on the sound waves and transmitting them to the eighth cranial. It's going through into the electrodes and then being transmitted to the eighth cranial nerve.